Hi, everybody. Good afternoon. And it's my pleasure to begin this webinar entitled Leveraging RNA Sequencing to Identify Actionable Biomarkers in Non-Small Cell Lung Cancer Management. Over the next half hour, we're going to discuss certain aspects of this area. And if we go to the next slide, joining me today are two wonderful colleagues, Mark Matrana, who is the System Director of Precision Medicine at Ochsner Health, and Gary Grad, the Senior Medical Oncologist at Tempus AI. I'm Ezra Cohen. I'm the Chief Medical Officer of Oncology for Tempus. As we go to the next slide, what we'll really cover today is the current biomarker landscape in non-small cell lung cancer, the DNA and RNA sequencing paradigm. Dr. Matrana will take us through a case study, and then we'll have hopefully a lot of time for discussion and your questions. I'll point out that the Q&A tab at the bottom of your screen is the way to ask questions. Please enter questions into the Q&A, and we'll try to field as many of them as possible. We know that non-small cell lung cancer is almost the prototype for molecular testing as far as solid tumor oncology, and that comprehensive biomarker testing really does offer significant advantages to the patient and to the management of that patient. Because through that, we can identify matched targeted therapies. And over the course of the next 30 minutes, we'll show you how one can optimize the finding of those targetable alterations and, of course, implement appropriate therapy. If we go to the next slide, let's talk about the current biomarker landscape in non-small cell lung cancer. And here you see a breakdown of many of the actionable alterations that can be detected in non-small cell lung cancer. In fact, there are now 12 biomarkers with an associated FDA-approved targeted therapy, and you see them listed there. It turns out that about 15% of non-small cell lung cancers are in fact driven by these, by actionable alterations. Actually, 15% of these are gene fusions, and it really are it's the gene fusions that become more relevant when we're talking about the DNA and RNA testing, and we'll show you what we mean by that in the next few minutes. There are, of course, many clinical trials recruiting patients with these unique fusions. The fusions on the right side of this slide are illustrated with the purple triangles, and I think many of us in the audience are quite familiar with these, and in fact, I'm sure have used the relevant agents. ALK, ROS1, RET, NTRK, and MET. And the nice thing about this is that using the appropriate therapy often yields a significant and meaningful response rate and efficacy. So if we go to the next slide, let me turn it over to Gary to talk about optimizing detection of these gene fusions. Thanks, Gary.
Thank you, Ezra. Let's go to the next slide. And before we look at some of the clinical implications of identifying these fusions, we want to talk a little bit about the reasons why sometimes we can identify a fusion with RNA that can be missed on DNA sequencing. And this DNA sequencing failure to detect a phenomenon can occur when fusion breakpoints fall within the introns of the DNA. And this can happen with situations where we might have large introns, repetitive introns, or complex genomic events, as well as when we have low tumor sample. RNA sequencing assesses the transcriptional consequences of the DNA rearrangements, and therefore we can capture these even when DNA sequencing can miss it. Now, the real clinical impact of this will depend a little bit on the prevalence of this phenomenon occurring and how often it occurs in clinically relevant fusions. So we'll take a look at that moving forward to the next slide. So this is a study that was a collaborative effort with Tempus. In fact, Ezra was a co-author on this study. And this looked at a very large cohort of patients from the Tempus data set, over 80,000 patients, and identified patients who had fusions. And we can see in the gray box on the graph on the right, over 2,100 patients identified with fusion events. And of those, we can see at the bottom in the darker gray, 58% of those were deemed actionable. And by actionable, we used OncoKB level of evidence 1 or 2 linked to therapies to define actionable. Now, when we look at these actionable findings and we break down how many of these were seen with both DNA and RNA, DNA alone, or RNA sequencing alone, we get a sense of what the prevalence is of RNA being able to identify these fusions that could have been missed on DNA sequencing alone. And if we look over on the curve on the right, we can see 23% at the very top there were fusions that were identified, actionable fusions, identified with RNA that would have been missed on DNA sequencing alone. Now, this was a pan-cancer cohort across several different types of cancer, but it did result in a 29% relative increase of the ability to identify an actionable fusion in patients who had actionable fusions identified. Next slide. So let's focus a little bit more on today's topic, which is lung cancer. And this will use ALK as a paradigm for this phenomenon in lung cancer, where identifying these fusions is so important for first-line therapy decisions. This paper looked at over 7,400 patients with non-small cell lung cancer and had an ALK fusion prevalence of about 2.9%. And again, a very similar analysis to what we did in the pan-cancer cohort. If we look on the right, we can see that about 83% of ALK fusions were identified in both DNA and RNA. But over 15% of these ALK fusions were captured in RNA only and would have been missed with the DNA-seq only assessment. And that resulted in a relative increase of 18% more patients being identified with an ALK fusion by combining DNA and RNA. And obviously, the clinical implications of this become very important, not just for ALK, but we can extend this proof of concept to some of the things Ezra talked about on that very first slide, looking at things like RET rearrangements, ROS1, splice events like MET-exon 14, and even less common events like NTRK 1, 2, and 3 events. Next slide.
Great. Well,
so this time I'm going to reintroduce. Oh, sorry. I'm going to reintroduce Mark to share a case with us that we'll walk through and get some of his expert insights on. Thanks, Mark.
Well, thanks, Gary. Yeah, I'm happy to be here with you guys this afternoon, and I'm happy to present a case which I think will illustrate the importance of our RNA sequencing. So we had a gentleman who was 73 years old who presented to us with worsening shortness of breath and dyspnea on exertion. He had a history of obstructive sleep apnea. He used a CPAP at home. He had mild coronary artery disease, some hyperlipidemia, and GERD. And he presented to his pulmonologist, again, with worsening shortness of breath and dyspnea on exertion, and he underwent CT of the chest. Here he was found to have a 2.5 centimeter left lower lung mass, and further staging, unfortunately, revealed disseminated stage 4 disease. He ultimately underwent a biopsy, which revealed adenocarcinoma, which was consistent with a lung primary. And this tumor was sent to Tempus for NGS testing. And here we have the results. And so on his Tempus XT report, this is primarily the DNA report, 648 gene panel, we found no actionable mutations. He also didn't express PD-L1. So this is a patient who, at first glance, you would think would be going to a combination chemo immunotherapy regimen. However, when we took a little bit closer look, next slide, please, and we got the results of his RNA analysis and the XR report, we found, lo and behold, he had an exon 14 altered splicing aberration in his MET gene, right? Now he is eligible for treatment with capmatinib and tepotinib. So now we have 2 targeted treatment options for this patient that we wouldn't have thought of otherwise without RNA sequencing. This is good news for this patient, very, very good news for this patient. And so he was started on capmatinib. He tolerated the treatment very, very well. He had very few adverse events from it. His quality of life was maintained. And a few months later, restaging scans showed that he had a really robust partial response to therapy, and he continues on treatment to this day, a couple of years later down the road. So we're really pleased at the results of RNA testing in our patient population, because it just allows us to find more mutations, which lead us to better therapies for our patients. Thank you.
And so if we go to the next slide, let's talk about the case in question, Mark, and the whole idea of this dual testing of both DNA and RNA. And Mark, thanks for presenting that case. I think when we look at it, it's really a great example of a patient that I think would never have been recognized as harboring this MET alteration if only DNA sequencing was done. So if you can put into perspective for us, how meaningful is this that A, this was found, and B, the whole idea of doing both DNA and RNA?
Right. So when I explain these mutations, these activating mutations, these targetable activating mutations to patients, I often tell them this is like winning the lung cancer lottery, right? Because now this opens up a whole new world of treatment options for these patients. So we're no longer talking chemotherapy for this patient. We're now talking targeted therapy with a much better quality of life, with much better outcomes. And I don't think we can understate the value here, because really, I think it's the difference of living a year or two on chemoimmunotherapy versus living significantly longer with better quality of life, fewer side effects for patients. And the thing is, it is like the lottery, right? You don't win unless you buy a ticket. And in this case, you're not going to find the mutation unless you look for it. And so any technology that allows us to find more of these mutations and get more patients on the most appropriate therapies is bringing great value to our patient population.
Yeah, and it's interesting because I say that to patients analogously. I'll say something like, "Look, we don't know if we don't look," and the more information we have, the better armed we will be to combat this disease. I want to step back a little bit, and Gary, you explained to us, this idea of finding additional alterations. Can you tell us a little bit, why aren't these found in DNA? Why do we need to do the RNA transcriptome analysis to find these this almost 30% relative increase in the number of alterations?
Well, again, I think as we showed on that cartoon, I think one of the situations that arises are these very large introns where the fusion breakpoint just can't be captured by the DNA. Obviously, when we have low tumor content, we have a situation where we might capture it on RNA, but again, we need some tumor content to be able to run successful RNA-seq, but we may have a better capture of that. And then there are a lot of these fusions that do have complex genomic events, very promiscuous fusion partners, things like that can make it very difficult sometimes to detect on DNA. So the RNA, does capture that as being the result of a transcriptional consequence if it's in the DNA. So even if you can't capture that breakpoint with the DNA-seq, you're still capturing the fusion at the RNA transcriptional level.
Yeah, it's really about looking at it in a different way, using different sequencing methods to try to find these alterations. And it's not that the DNA sequencing falls short. It has very high fidelity. It's just that because of the nature of the event, DNA sequencing just has a hard time picking it up. Is that the right way to think about it?
I think it is. And I think it's important to realize, even though those percentages, 15% or 20% of these fusions being picked up by RNA alone, even in some of these less common events, each one of those represents a patient who can have a profound impact from getting on targeted therapy for those situations. And the argument always comes up about, well, if I start a patient on chemoimmunotherapy first and I find this later, I can always treat them. And I think we're seeing more and more data starting to come out that less patients than we realize ever get to second line therapy or beyond, that a fair number of patients drop off as they progress and their performance status declines after first line therapy. So if we can get them on a very effective therapy, we know that there's variable response rates in the context of immune therapy for some of these drivers, depending on which one. But again, I think we underestimate how many of those patients are going to go on to be able to handle second or third line therapy. So identifying them early at the beginning, getting them on a proper therapy. Guidelines, I think, have really come along to support this as preferred now. And I think it really is impactful for patients, even if it's still 10 or 20% of these patients. Each one of those patients has a profound impact on their treatment paradigm by identifying these up front.
Yeah, I want to talk about that further. And Mark, I see you nodding your head, and I want to go to you. You lead the precision medicine program at your center, or your health system, your lung cancer doc. What about that? I mean, what about people who say, well, it's a minority of patients. I can afford to miss it now. I want to get therapy started. What about those thoughts?
Yeah, I think those are great questions, and to Gary's point, when we start chemoimmunotherapy in a patient with one of these alterations and then switch, we know that patients have poor outcomes, right? They have more AEs, they have more immunotherapy related immunotoxicities in that case, and overall that line of therapy simply doesn't work well for these patients. And so when I explain it to my patients, because patients often want to get started on treatment immediately, right? They've may have been trying to get this diagnosis for quite some time. They've been waiting for their appointment with the oncologist. Typically, we try to have this data ahead of time. But in cases that we don't, what I explain it to my patients as is we can do this the right way or we can do this the wrong way. And if we do it the right way, we're going to use the data to get you on the very best therapy that has the best chance of working for you. When we explain it like that, patients get it, and I think doctors get it too, right? Of course, you want the right therapy for your patient that's going to have the best chance for them.
The other thing to keep in mind about these therapies is that patients respond quickly to these targeted agents. I'd love to hear Mark and Gary if you agree. I can think of a patient I treated. This is maybe about a year ago now. Who presented to an outside institution, widespread disease, unfortunately. She presented with a neck mass, and the reason that I was called in is they felt that it might be head and neck cancer. But she, upon looking at the entire story, it was clear that it was likely a primary lung tumor, and they were about to start her on, as you just said, Mark, on dual agent cytotoxic chemotherapy. And I said, well, hold on, let's get the whole molecular profile. She can wait a little bit of time, and there's no need to start therapy right away. In fact, she ended up having a ROS1 fusion, responded right away, almost a complete response, and she's still on therapy a year later. So very similar to what you the case you presented, but I think the things to illustrate is the response to these targeted therapies happens rapidly. So it's not like you have to wait an additional 4 months or 3 months to see these results.
Exactly. The response happens rapidly and it happens deeply. It's a deep response in many of these patients. So it's not uncommon to have near complete responses after a cycle or two of targeted therapy. And again, I think it's just getting the patient on the right drug that works for them.
Absolutely.
Yeah, and I'll just say from a practical standpoint, there's always an urgency and of wanting to get information quickly for patients, but it's almost more important to get the right information for patients, even if it takes an extra 3 days to get that information. And fortunately, we're getting results back quickly. I think it actually makes the argument for doing the DNA with RNA-seq up front, so that you're not in a situation where you're reflexing things. You get everything up front at that point of very quick turnaround time. Where you can really identify all of the markers necessary to really drive your decisions. in the most complete way and make the right decisions for the right patient at the right point of care.
Absolutely. Mark, did you want to make a comment? I was going to go to the questions from
Yeah,
the audience.
I was just going to say I couldn't agree more. And what we've done at our center is built in a workflow so that when the pathologist identifies a lung cancer, it's automatically sent for full sequencing. And by doing that, the oncologist already has the data when they meet the person for the first time, and they can make an appropriate treatment decision, have those conversations about what treatment's best with the patient. So I'd love to see more and more centers putting those workflows in place because it works.
I think that's the right model. I think that the sooner you get that started, the sooner the patient benefits. So bravo to implementing that.
Ezra, one more point I'll make too, and I don't want to just leave it go without saying it. And I know we think it all the time and we're aware of it, but we identify a lot of patients' eligibility for clinical trials off of fusions identified on the RNA-seq. And it's a really important aspect because there are some really interesting, impactful trials going on if these fusions are identified. And I don't want to underestimate the importance of that either.
Yeah, absolutely. Looking at further lines of therapies, combinations, newer agents, more selective agents, and yeah, the field is still progressing. Great point, Gary. Let me go to the. We're getting a lot of questions in the Q&A, so keep sending them. Thank you. Thanks to the audience. Let's go to a couple that are specific to the case, Mark, if you don't mind. So. The first question is, how did you manage edema from capmatinib, assuming the patient had edema, but even if they didn't, how do you manage it?
Yeah, this patient didn't have a huge problem with that. That it is true that edema can be an issue with this drug. We take a multimodal approach, right? So we use diuretics as necessary. We use compression, we use elevation, and we have a very aggressive physical therapy edema clinic that helps with that. And so I would say even if you don't have that resource, find a physical therapist, an occupational therapist who has an interest in this, who knows what they're doing in terms of management of edema, and work with them because they can really be a godsend in helping these patients manage that side effect.
And then a second question related to the patient case, and then I'll move on to the more general questions. Real quick, Mark, what's your second line treatment for MET exon 14 skip alteration?
Yeah, and I think that's that's a tough one because a lot of these drugs have good first line options, but then we don't have a lot of good second line options. So we always look for clinical trials, and I really like Gary's point about clinical trials. And if you open any of the NCCN guidelines, every single one of them on the first page, it's got a big box and it says the very best treatment for any cancer patient is on a clinical trial, any cancer patient. So I always say, the standard of care in our field is clinical trials, right? It's not an alternative. It is clinical trials. And so we always try to get these patients on clinical trials when possible. That said, if we can't, then we're looking at, chemotherapy, immunotherapy. We're trying to push that further and further down the line as far as we can. But a lot of these patients, if they get through a couple of lines of therapy, that's ultimately where they'll end up.
Yeah, Mark, I think you already said the answer to this question, but I just want to make sure. We talked about the questioner asks, what is the impact of uncovering a specific gene fusion? And I think we talked about that.
Right.
But then it goes on to ask, do you run DNA sequencing first and then follow up with RNA, or do you run them concurrently?
Concurrently.
Yeah, I think that's your workflow.
Yes.
Yeah, and Gary, you made the point that you get answers quicker if you do it concurrently. Great. Let's go to sort of a pan-cancer question. I think this is an interesting one. Do you perform XR on all stage 4 cancers, or have a preference based on the primary site or malignancy? Mark, I'll let you take that one first, and Gary, I'd love to hear what you think about that too.
Yeah, we do it on everybody, right? Because we don't want to miss those intract fusions, and then those can occur in any cancer, and they have drugs that are pan cancer approved, right? So, and I honestly don't want to miss any of these alterations, and so I don't think about it really as two separate tests. I think about DNA and RNA sequencing as just an appropriate NGS panel for these patients.
Yeah, Gary, what do you think?
Yeah, I agree with that. And we also consider our default tissue sequencing is both the XT and the XR, which is the DNA and RNA. We've actually shared some data previously at some meetings and publications, where, as Mark said, some of the tumor agnostic biomarkers, if we look at our NTREX, over 20% of those were identified on RNA only in our data set. Our RET rearrangements was over 10%, another tumor agnostic biomarker. FGFR was around 20%, ROS1, a substantial number of patients were seen in RNA, not DNA. So a lot of actionable fusions across a multitude of diseases were really identified with a similar proof of concept as we showed for lung cancer here today.
Yeah, and yeah, I can think of certainly patients in my practice who have where I found these fusion events, would never have expected it, and all of a sudden I've got a great option for therapy. And you're quite right, Gary. The database that you talked about was a pan cancer cohort, not restricted to lung. A couple of practical questions now. My lab provides DNA sequencing from this questioner. How can I get RNA sequencing? And I think that order XR would be our answer. So Tempus has you can, if you're required or prefer to order NGS DNA sequencing from a different provider, you can just order the XR, that is the whole transcriptome, from us. Of course, you can also order the XT panel, the 648 gene panel that Gary mentioned, in addition to whole transcriptome. A question about turnaround time. What is the turnaround time for XT and XR results? Gary, can you field that one?
Yes, we're pretty consistent lately. We can usually turn around our tissue sequencing once we receive a specimen in 10 to 12 days with both the DNA-seq and the RNA results. So yeah, it's been pretty consistent.
Yeah, it's actually lately we've just inched right below
Yes.
10. We're about 9 days, but yeah, I think 10 is a fair number. So really, when you think about it, and Mark, I'd love to hear what you think about that. A 10-day delay to get the right information at the right time, to me, is worth it. What do you think about that? Is that reasonable?
Absolutely. No doubt about it. I think 10 days is very, very quick. If you're ordering this at the time the pathologist makes the diagnosis, the report's not even going to be finalized for a couple of days, right? And then by the time the patient actually gets into an appointment with an oncologist, you're looking at least another week or two, if you're lucky, right? And so if you're ordering it up front, you're going to have your data by the time the patient has their first appointment with the oncologist. Now, of course, if you're waiting to the point where the patient meets the oncologist for the first time, now you have 10 days that you have to wait. But I still think unless the patient is in some sort of huge visceral crisis or something that would really require hospitalization and treatment inpatient, then it's certainly worth the wait to get the patient on the appropriate therapy.
Yeah, almost all patients can wait that interval. But you're right, taking a systematic approach and integrating that type of testing reflexly really makes a lot of sense.
Yeah.
Here's a forward-looking, question. It's clear that RNA is important to include for all lung cancer patients. What about the resectable stage 1B to 3 non-small cell lung cancer cohort? How often would you include liquid biopsy, so ctDNA, concurrently with solid tissue NGS? And I'll extend the question a little bit. Is it also important to get RNA, whole transcriptome, in those patients? I'd love to hear from both of you. So earlier stage patients, what do we do there?
We just test all of our lung cancer patients at any stage, regardless of stage, with full NGS. And I'll tell you why we do it. Often the pathologist doesn't necessarily know what stage the patient's going to be if they're waiting on a PET scan or that sort of thing. And that said, it would also make it much more complicated for a pathologist to try to figure out, okay, well, you know, this patient we're going to order this, and this patient we're going to order that. It's just much simpler to just do it on everyone.
Yeah, so lung cancer diagnosis just reflects to the testing. Is there a benefit to it in earlier stage patients?
Well, certainly the earlier stage patients, there are some targeted therapies approved. So EGFR, so on and so forth, are approved. I can't personally think of a case where we found a fusion that made a difference in a very, very early case. But you know, we'll keep looking.
Yeah. Yeah, there are some data, of course.
Yeah.
Gary, I don't know if you wanted to say this, but we are at time. So were you going to talk about the ALK data?
Well, there's ALK data, and then the Nautica-1 trial is going to be reporting out. So we're going to have a number of biomarker trials informing perioperative therapy in the resectable and even biomarker-driven cancers in unresectable patients for what to do in maintenance setting after chemo-RT. So I think we're going to have a lot more relevance to early-stage biomarker testing in lung cancer, including the fusions.
Yeah, yeah, great way to put it, Gary. Thanks. Well, we are at time, a little bit over time. My apologies. Got carried away with some wonderful questions. A lot of questions that we didn't get to. We are recording them. We'll get you answers to all your questions. We didn't get to talk about the circulating tumor DNA aspect of it, but there is a webinar on circulating tumor DNA next week. So please look for that announcement. I want to sincerely thank both Mark and Gary for wonderful presentations and discussion, and thanks for answering these terrific questions. Thanks to the audience for tuning in today. Hopefully you enjoyed it as much as we did, and we look forward to further discussions. Thanks, everybody.
Thank you.